Yeah, there's something going on in the background.
किसका आवाज आ रहा है?
हाँ वी आर लाइव सर.
अमित की आवाज आ रहा है पीछे बैक में लेडी का.
Yeah, there's some sound coming in the background.
Yeah, I think now he has switched it off. Uh,
Okay.
Welcome everybody again to MSPRA and Maharashtra College of Radiology webinar series. Today we have Dr. and Professor Ravi Ramakantan sir, who will be giving a talk on a very difficult topic of bone dysplasia. I'm sure that people will get some knowledge and clarity on the whole system of bone dysplasia and how to reach to a logical conclusion on the type of the bone dysplasia. So I'll give it over to now Professor Sir Ravi Ramakantan sir. Over to you, sir.
Thanks, Amir. Good afternoon, good evening, whatever. Like I said last time, in bone tumors, an average radiologist who's not in an academic institution will seldom see a patient with skeletal dysplasia. And like in bone tumors, you could be referred this from a pediatrician often, sometimes from an orthopedic surgeon, and occasionally from an endocrinologist. The general opinion, general feeling amongst radiologists is beja fry. Bone dysplasia is beja fry. You say chondroskeletal dysplasia and you can dispatch that off. The other reason, if there are residents, I believe there are residents here, is that in an exam you could get skeletal dysplasia as a long case, as a short case, as a spot. In fact, for my MD, I had an MPS as a long case. That's beside the point. Exams come, exams go, you fail, you pass, donkeys pass. I keep saying everybody passes. The reason that you should know about skeletal dysplasia is that you'll see the real reason why you should know about skeletal dysplasia towards the end of this talk. If nobody else can read skeletal dysplasias, you should have some passing knowledge. I'm not saying if there are 50 people in the audience, each one of you should know about skeletal dysplasia. All that I want from this lecture is that you do not dismiss of skeletal dysplasia saying that this is not my cup of tea. This is not my beja fry. So what I'm going to do now is a very basic framework of how you could look at skeletal dysplasia and make a reasonable diagnosis. I've been doing skeletal dysplasias from 80, 85, whatever. And the cases that I get sent now are the so-called difficult ones. But an average radiologist who sees skeletal dysplasias on the first time can often make a diagnosis fairly easily because what you see commonly are the common ones, and that is what I'm going to cover now. There are two things that are important, or shall I say preferable, when you see a patient with skeletal dysplasia. Often you get radiographs, you don't see the patient, you don't have clinical history, but if you could, two important points that you should know about the patient is the patient a dwarf and is the mentation normal? If you know these two things, it's extremely easy to make a diagnosis in common skeletal dysplasia. So the first thing, and this is a beautiful quote from Arthur Clarke, homework for you, Google Arthur Clarke and read a little bit about him, a great astrophysicist, and he has written a lot of general public books on interplanetary travel. So this is it. The first thing that you should be able to identify is that this is skeletal dysplasia. Now again, I want to make one extremely important point here. The pattern of skeletal dysplasia that you see in our country is somewhat different from what you'll see in Western textbooks. And this is easy to understand. We have our own gene pool. We do not see something in the pattern or percentages of what you see in the Western world. And often you'll find that this type of skeletal dysplasia is in those communities where there is a lot of consanguineous marriage. Not that it is important to ask that question, but it is useful to know if there is consanguinity, and then you realize how so much of this can be avoided. So the first thing, therefore, is to identify if this is indeed a skeletal dysplasia. Now, I didn't talk to you about metabolic bone disease, but one of the clear differentiators from metabolic bone disease and skeletal dysplasia, where you see a view box full of X-rays, is that in skeletal dysplasia, the bone trabeculation, the bone density is often normal, not always. There are important exceptions, common exceptions, but by and large, the trabecular pattern is normal, whereas in metabolic bone disease, the trabecular pattern is abnormal, by and large. Important exceptions exist. So if you see a whole lot of X-rays, the first thing is, as a radiologist, you will get by 1 to 3 years a general sense of how a normal bone looks like. Now, when you see, you're walking on the corridor in a hospital, when you see a patient with skeletal dysplasia, with no experience of skeletal dysplasia, you can say that this child is abnormal or this adult is abnormal. That comes from experience. You've been seeing human beings all your life, and you can look at this patient, and in a vast majority, you'll say that this is abnormal. If you are a little more experienced looking at the patient, you can say that this is a skeletal dysplasia. So that comes from habit of looking at normals. So when you want to look at skeletal dysplasia, by and large, looking at the bone, you will be able to say that this is some form of skeletal dysplasia. This requires no teaching. This requires just a little bit of temporal lobe memory of seeing normal bones day after day. So this is the first question. Is this a skeletal dysplasia? But there are two things that you're looking at. I talked to you about this. There is bone texture and bone density. Now, when I talk of texture, that is something that comes with a little bit of greater experience than bone density. By and large, we are able to say that the bone density is less, and it's very easy to tell when the bone density is more. So the bone density part of it is fairly easy. Bone texture requires a little bit of experience. So when I say coarse trabecular pattern, you think of Rickets. Rickets is coarse trabecular pattern. When I say uniform density without trabecular pattern, think of scurvy, which has no trabecular pattern at all. If you've not seen a patient with scurvy, if you have not seen a patient with Rickets, remember these words: coarse trabecular pattern, crisscross trabecular pattern is when you see abnormal texture, and when there is uniform featureless pattern, you will call that as a soft or non-coarse trabecular pattern. Bone texture is often abnormal in metabolic bone density. It is not so frequently absent in skeletal dysplasia. These are words, okay? You must be imagining what is going on, so much description of word. But if some of this rubs on you, as we see examples going forward, you'll realize that these words are important. So bone density is simple. By and large, most of us can tell the bone density is less than normal. Now, bone density less than normal is not common in skeletal dysplasia. It is either normal or more. But there are a group of skeletal dysplasia which are characterized by less than normal bone density. We'll see examples of that. And they are easy to pick up because they are uncommon, and the presentation of decreased bone density is classical of few common diseases. Okay, so many words here, but remember these two words: texture and density. Now, this is very interesting. Okay, if there are residents here, I want you to carefully listen to what I'm saying. It has nothing to do with skeletal dysplasia. It has everything to do with what you are as a physician, as a resident, as somebody who is learning, and somebody who wants to teach. On the left is an abnormal human bone. What I mean by human bone is in vivo X-ray or a radiograph, if you will. On the right are pictures of dry bone, of femur. So when I want to talk about, for example, Google something called a Sphinx index. which is a sign or measurement of osteoporosis for categorizing osteoporosis of 5 different categories. Now, Singh's index, please note this down. I mean, I'm talking mostly to residents. If consultants want to do it, you will find it extremely illuminating to learn about these things. Day-to-day practice of radiology, same reporting, same shit, is horrible, right? You want to do something different. Now, these lockdown days, you may have more different, more time, and I want you to get inspired by reading some of these great minds. It's called a Singh's Index. In fact, his first name is Manmohan. Manmohan Singh is an Indian after whom the world looks at osteoporosis in classification. He was the one who first classified osteoporosis. It has nothing to do with today's talk. It is just that if you read things around what you learn, you find radiology more interesting, even a topic like skeletal dysplasia more interesting. So these are, on your right, are dry bones. So when I wanted to talk about Singh's index of trabecular pattern in the neck of the femur, I go down to this is about 1 year back, okay? I go to GS Medical College, Muscofy the chief of anatomy there, because you can't get dry bones out of the hospital easily. So I get official permission, take these bones to our hospital, and I myself have taken these pictures, okay? Why am I saying that? Because you are learning your enthusiasm to do things. When I was in a resident faculty in KM, we had a whole lot of gray bones of normals, right? So if you feel inspired, if you feel wanting to do the out of the ordinary, I'm not saying extraordinary, out of the ordinary, it makes learning so much more fun. You can always say, kiske paas time hai? I don't want to answer that question. If you're going to say, kiske paas time hai, there is no learning happening along these terms. So this is a way of illustrating normal bone and abnormal bone. I mean, if you look at the femur on the right, the lower end of the femur and the upper end of the femur, you start admiring how human evolution has happened. Now we went bipedal 4,000, was it 4,000? Something like that, I don't remember now. 4 million years back, yeah. So look at the trabecular pattern of the lower end of the femur. They are all vertical. I want you to look at the trabecular pattern of the calcaneum, the trabecular pattern of the vertebrae. And of course, you look at the trabecular pattern of the femur. The trabecular pattern of the femur, because there is a neck shaft angle, has evolved to give you the best strength possible. Now, this has been proved by physical experiments. Look at the trabecular pattern of the femur of an elephant, right? The lower end of the femur of the elephant looks similar. You read around a topic when you have time. You may not have time as a resident, but when you grow older, you'll have more and more time and you want to read around something. So you get fascinated. And when you feel fascinated, you feel inspired to learn. Now contrast that, the images on the right, with an image on the left, okay? Look at the middle third of the shaft of the tibia. I don't have to tell you that the right shows normal trabecular pattern, the left shows abnormal trabecular pattern. Here, for example, it looks as if, look at the upper end of the tibia in the image on the left, okay? The first top 2 centimeters or 3 centimeters or whatever. And then you look at that, forget the expansion of bone, forget all that. Just look at the trabecular pattern. It looks as if somebody has taken a brush and smudged that bone. So this is abnormal trabecular pattern. I'm not telling you what type, what name, so on and so forth, but trabecular pattern on the left is abnormal, where it is not coarse, but it is the opposite of coarse. Call it what you will. In fact, here it's called ground glass opacity. So this is how trabecular pattern is abnormal. And I'm not showing you one of Rickets, and all of you have seen Rickets, where the trabecular pattern is coarse. Why does it happen coarse? It happens coarse. I mean, we have to realize that it's not just osteoblasts. A lot of what happens in bones, in normal and abnormal, in skeletal dysplasias, has to do with osteoclast. Normal bones, for example, form from a mold of cartilage, osteoblasts come and lay, and it keeps on happening. But if the osteoclasts do not take out excessive bone, you will have something which is extremely sclerosed, right? So in skeletal dysplasias, which have coarse trabecular pattern, there is not always, but often excessive activity of osteoclasts. The whole pathophysiology of skeletal dysplasia is again fascinating. Not all of this has been understood. Much of it is still unknown. We know that this happens, but in some important ones, we know why it happens. So beside that point, look at normal trabecular pattern on the right and abnormal trabecular pattern on the left. So I'm showing you this because this is the one that is difficult to understand in radiography. And this is the one that can create confusion between metabolic bone disease and skeletal dysplasias, right? So when you see ground glass opacity, that's the word I want to use, you know that this is something, a particular entity, which is a skeletal dysplasia. Okay, no names now. This is just ground glass opacity. So the first thing is trabecular pattern. I mean, you think about trabecular pattern, it's so fascinating, right? It's not a joke that we have this kind of trabecular pattern. It's not a joke that we get coarse trabecular pattern in the diseases that produce coarse trabecular pattern. And you have to think about what is coarse trabecular pattern? Where does it come from? Okay, now we have two images. I hope you're able to see where you are sitting. The one on your left is increased bone density. Ask a donkey, right? Ask a horse, ask a mule. That person will say that this is more wide than normal. Okay, first MBBS student. I don't have to explain. This is more than normal. The left one. The right one, you can hardly see the image. If you're like in a sitting room, I mean a lighted room, you can hardly see. On the right, you have images where the bone itself is hardly seen, but you can see the end plates of the vertebra. So again, we go back to this. This is abnormal texture. This is abnormal density, which is either more or less. By default, by and large, not always. Again, there's nothing like always in medicine, almost never that there is always. If you have increased bone density in a child, okay, it's almost always a skeletal dysplasia. If you have increased bone density in an adult, it could be something else, but it could also be skeletal dysplasia. On the other hand, if you have decreased bone density, it's more likely to be a metabolic bone disease than skeletal dysplasia. So I'm not going into which is which. I'm just showing you here abnormal bone texture and abnormal bone density. Now, look at this. I have not shown you coarse trabecular pattern. Why is that so? It is rare in skeletal dysplasias to find coarse trabecular pattern. Coarse trabecular pattern, by and large, 95 out of 100 times, is a pattern that you see in metabolic bone disease. Yeah, so this is smooth bone, which can often be in a common skeletal dysplasia, and bone density, which is increased, which is almost always in the pediatric age group, a skeletal dysplasia, and bone density that is decreased is osteoporosis, run of the mill, you see it all over the world. So this is the first step. Learn to understand bone texture and bone density. Now, when you have a patient in whom, now you are talking of human beings now, radiology has still not come, right? You have a patient in front of you, you have a pediatrician on the phone, I have a patient in whom I'm suspecting a skeletal dysplasia, what X-ray should I do, right? Often they don't do, they do any damn thing that they want, right? Not realizing that radiation is neither free nor safe. So if you are asked, and you will be asked, if you make yourself wanted, you will be asked. If you contribute to patient care, you will be asked every single time. That's the object of my lecture, right? You can learn radiology from books, but I want you to make a conscious effort to be a part of clinical care. So if you are asked this question, I have a patient suspected to have skeletal dysplasia, don't do head to foot epilateral. completely stupid, unwanted. It occupies a lot of table time. It's a lot of radiation. It's unwanted. And if you're in a private setting, costs a whole lot of money. The other reason you don't want to do a skeletal survey every single time is that many times patients have had x-rays done in the past. And doing skull epilateral to grade 2 epilateral is completely stupid, right? That's the most important reason. The rest fall in place in terms of cost of radiation, cost of actual costs incurred by the patient, so on and so forth. So this is where you contribute right at the beginning by telling people, by broadcasting from rooftops, that when you want to do a skeletal survey for skeletal dysplasia, don't do head to foot, AP and lateral, sometimes oblique. So this is the ground that you should cover. I'm not repeating what I have written here. Now, lumbar spine is a lot of radiation. So you don't have to do AP and lateral. You have to do lateral, which is perhaps the largest amount of radiation that you can give in any X-ray of the human body. And long bones, again, long bones, just AP. You don't have to do AP lateral. You are not looking at deformities. You're not looking at exact details from a point of view of a fracture, for example. You are doing a skeletal survey. The word is survey. And this is enough for most patients to make an initial diagnosis. Also note that there is no skull AP and so on and so forth, right? If you're asked about this, if you're asked, for example, tell me 2 X-rays that I have to take for a skeletal survey because of the pattern of disease that we see, and I'll come down to that a little later, you do both hands AP, which is the least radiation that you can get, and you do pelvis with hips. And that's it. That's the beginning. The rest of it will fall in place. I mean, so much diagnosis of common skeletal dysplasias can be made just with hands AP, right? Pelvis with hips is optional extra. So this is important. Not exactly what the list that I'm putting up here, but the fact that you have to be extremely prudent in the number of X-rays that you take in skeletal dysplasia. These are bachulo. They have gone from town to town, from consultant to consultant. Everybody has taken AP lateral, AP lateral. The whole burden on the patient, whole burden on the radiology system. So I want you to be prudent. I want you to be knowledgeable. And first look at the old radiographs if they are there. I mean, that goes without saying. And if they give enough information, then don't do more X-rays, right? You tell who will refer the patient, not required, this is the diagnosis. But if you have to do, this is all that you need to do. This is an important slide, perhaps the most important slide, which can be remembered very easily without great knowledge. Now, I don't know if anybody here in the audience thinks that this is normal bone density. I do not think anybody in the audience will think of this as decreased bone density, right? I repeat, donkeys will tell you that this is increased bone density. I have a lateral, I have a lateral. Now, if you look at this lateral, you will see that the skull base of great density, increased bone density, and the skull ward is also increased bone density. By and large, in most skeletal dysplasias, you will find that the increased bone density in the skull is at the skull base, right? And again, this is a pattern which is related to decreased osteoclastic activity. So this is increased bone density. So we have the differential diagnosis of common ones. What I'm going now is just common, which will constitute a vast majority of skeletal dysplasia that an average radiologist would see. So if you have increased bone density on this initial skeletal survey, you think of 3 conditions, right? All of you have already said osteopetrosis. Now this is something, I mean, I can do this in dream. I can do this when I'm on a ventilator. In the sense that these 3 names are extremely common. These are important to remember, and these are important. I'm sorry, these are easy to differentiate. It's not a big deal. So if you see increased bone density, there are 3 conditions. I'll rattle it out for you. Osteopetrosis, pycnodysostoses, and cledocranial dysostosis, right? Osteopetrosis, pycnodysplasia, and cleidocranial dysostosis. Each of these conditions has increased bone density, and these are the common ones of all sclerotic bone dysplasia or osteosclerotic bone dysplasia. I will repeat: osteopetrosis, pycnodysplasia, and cleidocranial dysostosis. Homework: if you are interested, find out why these conditions are called what they are called. It's always fascinating to know what happens in medicine, right? So why are they called? Because if you know why they are called what they are called, you will automatically understand the radiological or phenotypical manifestations. Now, how do you tell one from the other? It's easy. It's possible virtually every single time. And if somebody tells you other way, don't believe, right? Now, if you have sclerotic bone dysplasia and you want to know which of the three this is, in pycnodysplasia, things happen that you don't see in osteopetrosis and cleidocranial dysostosis, right? In osteopetrosis, the skull looks like this. Highly dense, the skull vault is dense, you can hardly see the fontanelles. So this is classical osteopetrosis. Now, this is a uniform in all skeletal dysplasia. Every bone from head to foot is involved. I mean, having said that, it's not as if every bone is equally involved, but every bone is involved. That's one way of telling that this is a skeletal dysplasia. Now, look at this increased bone density. So you have increased bone density, and all of you now see the bone within bone appearance. Now, bone within bone appearance can be seen in any of the three skeletal dysplasia that I talked to you about: osteopetrosis, pycnodysplasia, cleidocranial dysostosis, but is most dramatically seen in osteopetrosis. Now, I want you to admire the image on the right. You see bone within bone. Why don't you see it normally? You don't see it normally because the bone that is laid down is resorbed by osteoclasts as new bone formation happens. So you would not see the primitive model of the bone that was 2 years back. That has been resorbed by osteoclasts. That does not happen in sclerotic bone dysplasia. You see bone within bone as if somebody is telling you that I was like this 2 years back, I'm like this now, tomorrow I'll be like this. That's where your cartilage, that's where the cartilage is seen. So this type of appearance of sclerotic bone with bone within bone appearance is by and large 95 out of 100 times osteopetrosis. But you can still see it in pycnodysplasia and cleidocranial dysostosis. It's possible because both of them, both the three of them, that's interesting, have the same pathology. Now, if you look at the image on your left, this is a spot diagnosis. Why is this a spot diagnosis? You have increased bone density and the liver and the spleen are enlarged. Why does this happen? What are the big difference between osteopetrosis and pycnodysplasia and cleidocranial dysostosis? Osteopetrosis kills. Osteopetrosis makes life difficult. Why is that so? Because in osteopetrosis, there is no real marrow. The full marrow is gone, and you have extramedullary hematopoiesis, and you get massive hepatosplenomegaly, and you can get paravertebral shadows of extramedullary hematopoiesis. That's one part of it. Osteopetrosis is bad because the patients are severely anemic and they have all counts haywire in the blood. But more importantly, osteopetrosis in the skull, all the foramina become narrow. They don't become narrow. They don't become narrow. They are not resorbed, so they don't achieve their normal diameter. So when the optic foramen remains narrow, the patients can go blind. It happens. Imagine the tragedy, right? Not only that, the patients can go deaf of internal acoustic meander. That's unusual in any pathology in the human body. But this can happen in osteopetrosis. And worse, the foramen magnum is small and you can have quadriparesis because of the compression of the spinal cord at that level. So osteopetrosis is a massive disaster. And therefore, you should be, and it's common. In our country, it is common. So you should be able to tell osteopetrosis from pycnodysostoses and cleidocranial dysostoses. One way is to look at whether there is organomegaly or not. If it is present, then it is not pycnodysostoses or cleidocranial dysostoses. That's fine. We are looking at bones. So looking at bones, how do you tell one from the other? So I told you that the skull vault is normal in osteopetrosis. Remember that. You want to remember one thing about skeletal osteosclerotic bone dysplasia, that the skull vault is normal. What I mean by normal is that it's dense, but there are no breaks in the skull vault in osteopetrosis. Now, if you see pycnodysostosis and even cleidocranial dysostosis, this is what you'll find. The skull wall density is not too high. That's fine. The skull base density is high, but it is never as much as it is in osteopetrosis. But you have wide open fontanelles. You can see here, this one, the anterior fontanelle is completely open. This is open. This is diagnostic. The posterior fontanelle is open. I don't know why that happens, but it happens, right? If some of you are curious, try look up why that happens. So cleidocranial dysostosis and pycnodysostosis are sclerosing bone dysplasias where the skull has wide open fontanelles. In osteopetrosis, it doesn't happen. So you require just one foot, lateral view of the skull. And if you have a sclerosing bone dysplasia and the skull vault is open, you can say that it is one of the other. Pycnodysostosis or cleidocranial. I changed the order because pycnodysostosis is vastly more common than cleidocranial dysostosis, right? Cleidocranial. Cranial, skull vault, and cleido is clavicle. So if you want to differentiate, now this is very interesting, whether we should say differentiate between or just differentiate. I don't think you should say differentiate between. So if you want to differentiate cleidocranial dysostosis from pycnodysostosis, you do one chest X-ray where you see that the clavicle is not absent all the time, right? Half the time it's absent. The other half of the time the clavicle is hypoplastic. So in an exam, you will often get a spot of a chest X-ray where the clavicles are gone, no clavicle. You look, and you think it's normal, but then it will strike you that the clavicles are absent. So if you see a sclerosing bone dysplasia in an exam and a chest film, close your eyes and say this is cleidocranial dysostosis, because no one else will put a chest film of sclerosing bone dysplasia if it is not cleidocranial dysostosis. Confusing, right? Sclerosing bone dysplasia, three conditions: osteopetrosis, pycnodysostosis, cleidocranial dysostosis. Look at the skull. If the fontanelles are wide open, then it is pycnodysostosis or cleidocranial dysostosis. If they are normal, it is osteopetrosis. How do you tell number 2 from number 3? You do a hand X-ray. Do I have one? Okay, this is cleidocranial dysostosis, no clavicle. Just slightly increased bone density, but cleidocranial dysostosis, often like pycnodysostosis, does not have the same sclerotic activity that you see in osteopetrosis. Okay, now let's look at the next one. So somewhere along the line, I think I'll show you a hand X-ray in which you will see that the terminal phalanges are resolved, and that is classical of pycnodysostosis, not of osteopetrosis or of cleidocranial dysostosis. The other thing, when you look in the mouth of the patient, the teeth are completely abnormal in pycnodysostosis and sometimes in cleidocranial dysostosis. The way I am talking, you will realize that there is a whole lot of overlap between pycnodysostosis and cleidocranial dysostosis. What is the overlap? All of them have bone density which is more. Both of them have bone density that is more. Both of them have wide open fontanelles, much more in pycnodysostosis. Dentition is abnormal, much more in cleidocranial dysostosis, and distal phalanges are resolved much more in pycnodysostosis. Of course, clavicle is only in cleidocranial dysostosis. So that's an overlap. Human beings are trying to differentiate into categories which cannot be categorized because our genes don't know that we have to categorize. So there will be a whole lot of overlap. The more you do in skeletal dysplasia, the more expert you become the more you'll realize that there is a huge spectrum. Things don't fall into one particular place. So when I'll talk about it towards the end of it, right? So for your purposes, if you're beginning radiology, if you're appearing for MD or DNB, you will get classical cases. So if you have classical cases, you can tell. Now, if you look at this film of pelvis with hips, if you look at the acetabulum, the supraacetabular region, you have bone within bone appearance. I get fascinated, not because it looks beautiful, but because there's so much bone pathology behind it. Now you see the fractures in this patient, right? These are horizontal fractures. These are not oblique fractures. What I mean by horizontal is that you take a ripe banana and break it, right? When you take a ripe banana and break it, try as much as you will. You can do it to a whole lorry load of ripe bananas. You cannot break it obliquely. They will break transversely. So when you see this type of fractures, that means the bone breaks horizontally. This is in fact called as banana fractures. It's always pathological, always, every single time, unless somebody has taken a sharp instrument and broken it, right? That's an unusual variety of trauma. So this is banana fracture, whether the bone density is normal or abnormal, more or less. If you see a horizontal fracture, it's a pathological fracture. Now this is so interesting here. Look at the left femur upper third. The bone looks so dense and still there's a banana fracture. Now these are brittle bones. So these patients can fracture. So add to the woes of all of these, they have anemia, osteopetrosis. They have abnormal things going on in the skull, and they can have fractures easily. And the thing is that these fractures don't heal. So that's a big deal. I mean, the human burden of osteopetrosis is phenomenal. Forget that it runs in family, right? Homework. What is the type of inheritance of osteopetrosis? It is bad. It's really bad. And it's common because the inheritance is dash, dash, dash. Okay? So look that up. So if you're looking at skeletal dysplasias in a country, and if you see sclerotic bone dysplasia, I repeat quickly what you should do. Increase bone density, look at the skull. Wide open fontanelle is not osteopetrosis. If the fontanelles are normal, it's osteopetrosis. Wide open fontanelles are pycnodysostoses and cleidocranial dysostosis. Look at the clavicles. Clavicles are normal, then it is pycnodysostoses. If the clavicles are abnormal, it is the other one. So let's move on. So this is sclerotic bone where you see no medulla, and this is classical of osteopetrosis. Okay, this sort of summarizes all that I said. Okay, but the last line, ligament calcification, is something I want to spend a little bit on. Now, when you see white bone, right, it doesn't tell you that I'm skeletal dysplasia. You have to look at various features. For example, abnormality of texture, coarse trabecular pattern, stuff like that. I repeat, coarse trabecular pattern almost always means metabolic bone disease, and that's what happens in the last one. So if you have increased bone density and you have coarse trabecular pattern, and if you have ligament calcification, it is not an skeletal dysplasia. Coarse trabecular pattern, very unlikely to be skeletal dysplasia. Coarse trabecular pattern, increased bone density, and ligament calcification, close your eyes, fluorosis. Common in our country. What did I say? Coarse trabecular pattern, unlikely to be skeletal dysplasia. Coarse trabecular pattern and increased bone density and ligament calcification, close your eyes, fluorosis. Okay? On the telephone, you can call it fluorosis. So knowing ligament calcification, knowing that there is coarse trabecular pattern, you can differentiate that from the skeletal dysplasia. I'm not even getting into clinical thing, right? If you look at the patient, if you know the clinical findings, all this is unwanted headache, right? So much is easier. You don't even think of ligament of fluorosis if you've seen the patient, if you know what the patient's problem is. But in an exam, you will be asked differential diagnosis of increased bone density. How do you tell one from the other, right? All bones affected, very likely skeletal dysplasia. Patchy bone affection, coarse trabecular pattern, one is fluorosis, the other is secondary hyperparathyroidism. All bones affected and increased bone density would be a skeletal dysplasia and ligament calcification separates secondary hyperparathyroidism from coarse trabecular pattern, from fluorosis. So if you have increased bone density, I repeat, increased bone density, abnormal trabecular pattern which is coarse, you have a metabolic bone disease on your hand. The two common ones, what I mean is common, they are common, right? In fact, so the two common ones are secondary hyperparathyroidism, which produces coarse trabecular pattern and increased bone density. Increased bone density in hyperparathyroidism can happen only in secondary hyperparathyroidism, only in no exception. Thank God for that. And if you have ligament calcification in such a setting, you think of fluorosis, only fluorosis. So sometimes life is easy. So why I'm talking on the asides of this is because sometimes you have trouble telling what is going on in terms of increased bone density, whether it's a skeletal dysplasia or not, if you have no access to patient records or seeing the patient. So that's one thing, bone density, right? So that's the easy part. And fortunately for us, that's the common part. I mean, an average radiologist will see this commonly. The other way of looking at skeletal dysplasia is this difficult part, okay? Because this comes with experience. You've seen something once, the next time you see something similar, you'll call it that. And I talked to you about Aunt Penny last time. I hope you look up Aunt Penny and why is it called Aunt Penny, right? A term which has been popularized by Benjamin Felsen. Why Gestalt? What does Gestalt mean? Homework. So the last line says it all. So if you keep seeing x-rays after x-rays of skeletal dysplasia or any damn thing, and somebody tells you that this is that, get that into your temporal lobes. And next time you see something like that, you know that this is something. It's so simple. So these findings are characteristic. So that is the second variety, second way of diagnosing skeletal dysplasia. Seen once, next time you see something like that, it is the same thing. Now, this is interesting. You will not find it in Western textbooks, right? And this is common. So you should know it. This is often thought of as skeletal dysplasia. But I saw one 2 days back in the hospital, right? And I closed my eyes and I said, this is not skeletal dysplasia. Why is that so? Because these findings are characteristic, absolutely characteristic. And I repeat, you will not find this in Western books, and it's common to our country and maybe other developing countries. What you see here, if you look at the trabecular pattern of the lower end of the femur and the upper end of the tibia, they are coarse. If you don't believe me, forget, okay? You see varus angulation of the femurs and you see varus angulation of the tibia. If you see that at any age, bilateral, symmetrical, no, bilateral, symmetrical. Symmetrical means bilateral, okay. Symmetrical varus angulation of both the femur and the tibia, close your eyes and say, this is Rickets. And no sign of Rickets here. This patient has suffered from Rickets at some point in life. There is no skeletal dysplasia. There is no other metabolic bone disease that does this. Varus angulation of both femurs, varus angulation of both tibia in this pattern. In the lower third, it's so characteristic. It's so fascinating why it happens. Why does it happen that in the lower third of the femur and the lower third of the tibia? I know the answer, but I'm giving you homework. You don't have to read about this. Common sense, right? And when did Rickets happen when you see something like this? So this is healed Rickets. And this is not a skeletal dysplasia. There is nothing. You have to tell the patient that this is not something that will go down from generation to generation, right? You don't have to worry. When you talk to patients with skeletal dysplasia, and I often do that, the question that they ask are stereotyped. When you come to that stage of talking to patients, you'll realize what I'm trying to say. They want answers because they have been sent to you because nobody else is able to make a diagnosis. I will show examples of that also. So I'm diverting from the main topic because skeletal dysplasia is something highly uninteresting. For an average radiologist who is looking at glamours, skeletal dysplasia makes no sense. But at some point in time, I hope some of you at least will look at these bones with a different view from the point of view of looking at a patient. So this is classical. Show me a book like this in a Western textbook and I will give you what you want. This is another thing I keep talking about. Indians are not 6 feet tall. They do not have blue eyes and do not have blonde hair. So the pattern of disease that we see in our country off and on is very different from what you read in Western textbooks. So you have to learn that these are different, and this is pathognomonic. I don't even know the pronunciation of that. I think pathognomonic, something like that. Yeah, pathognomonic is wrong. So it doesn't look like rickets, but it is healed rickets. And the only thing that the patient needs, if this type of varus angulation comes in the way of normal activity, is corrective osteotomy, right? Nothing more. You can't give tons of vitamin D now. You could do calcium levels, you could do vitamin D levels. If they happen to be abnormal, you could treat. By and large, those are normal. These are tombstones of disease that was present long back. Okay, so the only treatment is the important thing here is that this is not a skeletal dysplasia. So I talked to you about texture of the bone. Let's move on. Now this is, pay attention, wake up. Now this is, let's see, widened metaphysis. You can even say that there is cupping and fraying, but actually if you look at it carefully, there is no cupping, there is no fraying. The only thing that you have here is widened metaphysis. When you see something like this, for months and years, these patients have been given tons of vitamin D. Do vitamin D level is 60 or 70, sky high. But unfortunately, for the patient, this is not rickets. Why is this not rickets? Because the trabecular pattern is not coarse. Look at the trabecular pattern about a centimeter or 2 centimeters above the epiphyseal line of the femur. It's bang normal. The bone density is near normal. I don't say it's completely normal, but the bone density is normal. There is widening of the metaphysis, I agree, but there is no cupping. Look carefully. There is no cupping and there is no fraying. So first shot diagnosis is rickets, and often first shot diagnosis here is wrong. As a radiologist, it should take you just 2 seconds to tell that this is not rickets, because of the reason that I told you. Patients are treated with tons of vitamin D and calcium. So the thing that mimics rickets is spondyloepiphyseal dysplasia. Remember that, SED, fairly common. In fact, if you practice skeletal radiology, you will find 2 or 3 spondyloepiphyseal dysplasias in a year. So it's not uncommon. And you will find all that I told you. It's from orthopedic surgeon, from pediatrician, from endocrinologist, till somebody says, oh my God, this is not responding. Vitamin D levels are sky high. What is this now? So one look at it for the reason that I told you, this is not. So a dysplasia that looks like rickets but is not rickets is spondyloepiphyseal dysplasia. Okay, so this is what I said. So this is just start. You look at this and you know that this is SCD. And I'm not showing the rest of the X-rays. I mean, it's irrelevant because when you see something like this, you know that this is spondyloepiphyseal dysplasia. Look at this. The bones are short. It's obviously abnormal. I mean, it doesn't take much knowing to say that the bones are abnormal. Anytime in the human body, you see a bone coming out of bone, you see a bone coming out of bones, it is an exostosis. So if it is a single exostosis, it does nothing. It comes like giraffe's horns and goes away its own way, right? It seldom becomes a malignant lesion. So that's a single osteochondroma. That's not a dysplasia. That just comes. Now you have to understand, you look at osteochondromas isolation, you'll find that they are always close to the metaphysis and they are growing away from the metaphysis. Ask yourself why. Keep asking yourself why. It's fun. They're always the same. A single osteochondroma, which is not a part of syndrome, it's not syndromic like this one is. So here what's happening here is that the bones are grossly abnormal. The humerus is short, deformed, and there is an exostosis coming out of this. Now, this is important. People don't pick it up. It's missed time and again and again. So what you have to understand is that this is an abnormal looking bone. Now, how do you tell an abnormal looking bone besides that it is short? You don't have what's called a normal tubulation. You'll see that the normal bone, as it comes from the diaphysis, as it goes toward the widening of the epiphyseal region, there is normal narrowing, which is called tubulation. The Erlenmeyer-Falk deformity is the opposite of that. So when there is not normal tubulation, it looks like straight like this, parallel, vastly more parallel than normal. You know that it's a skeletal dysplasia, right? You keep looking at bones and a few skeletal dysplasia, you look at that and you know that this is skeletal dysplasia. Just normal tubulation of the bone is lost near the distal metaphysis. Now here, as I said, I keep saying donkeys, okay? Can pick this up as a short humerus, malformed humerus, bone coming out of bone is an osteochondroma, and in the context of all this is multiple exostoses, better called as diaphyseal eclasia. Now, you don't have to see 100 bones to make a diagnosis of diaphyseal eclasia because there is a deformity of the formation of the whole bone with diaphyseal, with the osteochondroma. Why am I saying this again and again? Because people fail to pick up this as an osteochondroma. Simple rule of osteochondroma. Anything that grows out of bone is a osteochondroma. Then you decide whether it's syndromic or not. Now, this is a real homework for all of you. What I mean is real homework. Google, within quotes, something called as bumpy bone poem. So when you do Google within quotes, it takes the exact phrase. Bumpy bones, it will not show you just bumpy, it will not show you bones alone, but it will look for bumpy bones. So you get bumpy bones and poem and read that one. That tells you the tragedy of skeletal dysplasias. It's a poem written by a patient, a small child. Okay, a child, not a small child, a child. But please read that poem for me. It don't take you more than 5 minutes, but it'll put the whole thing in perspective. Why skeletal dysplasia is something that at least some of you should want to look at and learn and diagnose. So this is abnormal bone, bone growing out of bone is diaphyseal eclasia. Why is the difference so important? Because in diaphyseal eclasia, the chances of an osteochondroma becoming a chondrosarcoma are about 20%. And it's extremely sporadic in an isolated osteochondroma. So it's important to know that this is diaphyseal eclasia. So this is a spot diagnosis. This is what I was talking as Aunt Penny or gestalt diagnosis. Okay, now this is the opposite side. Deformed bone, and people don't pick up. Now they may say that there is dislocation of the shoulder joint, irrelevant, completely irrelevant. The patient has other problems that is not bothered about dislocation of the shoulder joint. The bone is short, and you see just a short bump here. This bump is abnormal. The opposite side is what you saw before. So both sides are abnormal. In fact, you don't have to see both sides. You see something like this, it's a spot 100% diagnosis of diaphyseal eclasia. No other disease does this. So that's one part of gestalt. The other part of gestalt is that you have a patient who is, I told you in the beginning, it's nice to know if the patient is a dwarf and if the mentation is normal. And if the patient is a dwarf, whether it's a symmetrical dwarf, asymmetrical, all that is different. You don't have to get into that. But if you have a patient who has a skeletal dysplasia and you have a lumbar spine AP X-ray, I said do lateral at the beginning, but if you do have an AP X-ray, look at interpedicular distances, okay? I assume you know how to measure interpedicular distances. Listen to me carefully. In normal human beings, without exception, the interpedicular distance increases from L1 to L4, not L5, L1 to L4. L4 is the widest interpedicular distance in normal human beings, and L5 may be the same as or smaller than L4. But when you have a patient with a skeletal dysplasia and you look at the lumbar spine and you find that this doesn't happen, this rule is not followed. So the rule is broken. So when the rule is broken, what happens? The L4 interpedicular distance is not the widest interpedicular distance. Close your eyes and say this is achondroplasia. No other scale. See, I'm making it easy for you. Sometimes you can make spot diagnosis, like I said, gestalt by looking at few findings. We covered 3 or 4 of them, and these are common. So if you can make the right diagnosis in the common ones, what more do you want? So achondroplasia is not a big deal. You look at the patient, you may already made a diagnosis. When there are variants of something called as hypochondroplasia, which is a wastebasket diagnosis, when you don't know what's going on, you call it hypochondroplasia. So in those difficult situations, you look at interpedicular distances, and if L4 is, look at this one, L3, and look at L4. L4 without using a ruler. You don't often have to use a ruler, not required, eyeball. So L4 is smaller than L3. In fact, the rule is if L4 is not larger than L3, if it is the same as or smaller, often it is smaller, this is achondroplasia. You don't have to look at the whole of the rest of the skeletal survey to make that this is achondroplasia. The question would be not whether this is achondroplasia, as I said, it will be a clinical diagnosis, whether it is hypochondroplasia or achondroplasia. In hypochondroplasia, whatever that means, you don't get abnormal interpedicular distances. That is normal. So it's phenotypically achondroplasia and hypochondroplasia can look the same. Their outcomes are completely different. But radiologically, interpedicular distances are abnormal only in achondroplasia. Okay, so this is one second way. The first is bone density. The second is gestalt eyeball, and you can make the specific diagnosis of the point that I told you. The other way of looking at skeletal dysplasia, the common skeletal dysplasia, God's sake, okay. Sami told me there is no time limit. Good for me. Is the location. So this is simple. Yeah, I don't have to explain. Look at the location, and you can tell. Now, when I say location, it's not again, I mean, I have to keep saying this. They don't know. The skeletal dysplasias don't know that they have to be following this. So when it's epiphyseal, metaphyseal, or diaphyseal, it's predominantly in these regions. You can have an epiphyseal dysplasia with abnormality of the metaphysis. Ask yourself why, and vice versa. And diaphyseal dysplasia is an uncommon type of diaphyseal dysplasia by its very nature, because of non-tubulation of bone. It can have secondary changes in metaphysis and epiphysis. So what we mean by this is the predominant changes are in the epiphysis or metaphysis or diaphysis. So when you look at that, so this is what I call non-tubulation of bone. All of these are from the teaching files of the KM hospital. Look at 1456. Exam 1456, you make a diagnosis. Non-tubulation of bone, the so-called Erlenmeyer-Fast deformity. Why Erlenmeyer-Fast deformity? Google. So this is non-tubulation. Coming from the diaphysis, it comes to metaphysis and the epiphyseal region, it doesn't show the normal tubulation. So this is some form of dysplasia, straight off. Even if it's not so gross, anywhere in the skeleton, if you see non-tubulation of bone, it's very likely to be a dysplasia, always abnormal. So this is an abnormality starting from the diaphysis, going through the metaphysis. The epiphysis is relatively normal. So this is some form of diaphyseal dysplasia producing metaphyseal abnormality, non-tubulation. This is not primary metaphyseal dysplasia. Okay. So the common one that does this is craniodiaphyseal. Forget it, it's uncommon. But I'm showing this just an example of how the deformity can be present in the non-tubulation variety. So when you look at that, you know that this is an uncommon variety of dysplasia, the diaphyseal dysplasia. This is the skull of that patient. God's sake, this is uncommon. Why is this not osteopetrosis? In osteopetrosis, you see skull base affection. You do not see so much affection of the skull wall. Now look at the thickness of the skull wall here. It's 1.5 centimeter. That's not something that happens in osteopetrosis. You saw the examples of osteopetrosis that I showed you. Look at, imagine this one is very different in terms of skull wall affection, in terms of the width of the skull wall. And so if you look, if you are shown this, just one X-ray, you call it craniodiaphyseal dysplasia, diagnostic, no differential diagnosis. Repeat, why is it not osteopetrosis? The skull is also sclerotic, the skull wall is widened, does not happen in osteopetrosis, pycnodysostoses, or cleidocranial dysostosis. When you see something like that, with something like this is cranio-diaphyseal dysplasia. Uncommon, you have not heard it, you can forget it except in the exam. Okay. Now, this is what I meant. Babygram. Rickets, healed rickets. No. The bone density is near normal. And if you look at I'll show you. If you look at the metaphysis, there is no brush border appearance. It shows sclerosis, whether the patient has been treated or not. Now I'll show you the next one. This is what the metaphysis looks like. Look at the proximal metaphysis. You don't see brush border appearance. Look around the elbow joint. You don't see metaphyseal appearance. So the appearance of rickets is superficial. Bone density is normal. There is no brush border appearance. And though cupping may be present, there is no fraying. The important thing is the bone density is normal here. So you have to look carefully. The phenotype types abnormality is a different thing altogether. But look at the radiograph and put this in your mind that the metaphysis is widened, agreed. There is no fraying and there is no brush border appearance and bone density is normal. 10th time I'm repeating because this is an extremely common dysplasia in our country and often mistaken. In fact, it should never be mistaken because it's characteristically abnormal and diagnostic of metaphyseal dysplasia. There are 7-8 varieties of dysplasia, metaphyseal dysplasia. Look up the books and read. But the first thing, the first step is to make a diagnosis that this is metaphyseal dysplasia. This is another example of metaphyseal dysplasia in an older child. Okay, short bones, which doesn't happen in rickets. Sclerosis of the margins, no cupping, no fraying. Look at the lower end of the fibula. Okay, most people will call this rickets. This is not rickets because the rest of the epiphyses are normal, metaphyses are normal, and the bones are short, which doesn't happen in rickets. You may fracture, but the bones are not short. Look at the distal metaphysis of the fibula and keep that in your mind. This is not rickets, but metaphyseal dysostosis. I thought it was so important that I should put it down in words. Yeah, common condition, often mistaken. Do not mistake it ever. So there are multiple varieties of that. Now this is an important slide. So perhaps I keep saying this is the most important. This is not the most important, but it's an important slide. And because two conditions are common in our country. One is any of the MPS. The other is spondyloepiphyseal dysplasia or sometimes spondylometaphyseal dysplasia. So how do you tell MPS, any variety of MPS from spondyloepiphyseal dysplasia? So there are MPS with normal mentation and similar features as spondyloepiphyseal or spondylometaphyseal dysplasia. One X-ray, just one X-ray, hands. Look at the base of the metacarpals and sing a song. If the base of the metacarpals are square, this is not an MPS. What do I mean by square? The one on your left is square. The one on your right is pointing. Look at the lower ends of the radius and ulna. Looks similar. So how do you tell spondyloepiphyseal dysplasia, SED, from MPS? Is look at the base of the metacarpals. Works every time. Okay, almost every time. 99.9. Pointing at the base of the metacarpals is diagnostic of MPS. Of all the dysplasia that you will see, MPS perhaps is the most common. Luckily, it is not treatable, expensive, but still treatable. But the one on your left, squaring of the base of the metacarpals, is not MPS. The one on your right, pointing of the base of the metacarpals, is diagnostic of an MPS. Okay, I don't know why I did this, but I'm just emphasizing this. So this again is an MPS, right? So if you look at proximal to the wrist joint, you could call it spondyloepiphyseal dysplasia. The same thing, the widening of the metaphysis, sclerosis, the works. But if you look at the base of the metacarpal, they are pointed, and this is MPS. I'm not talking into which MPS. There are simple ways of doing that, but beyond the scope of this lecture. Okay, so this is of the spine. You could look at the spine. Again, there are differentiating points between various types uh, uh, of MPS looking at the spine. But this is important not because this is something to do with a different type of MPS. This pattern of pointed or bullet-shaped spine is classical of a dysplasia. Again, here, the pointing occurs because the ring apophyses don't develop, right? You keep asking why. Why is it pointed? Because the ring apophyses don't develop. And why is it set back and not set back? It's something to do with the muscle tone in these bachus. So looking at the spine, looking at the way the beaking is, looking at way the alignment of the vertebrae is, you can tell one MPS from the other MPS. Not often required because much of that is done by genetic analysis and also by looking at the abnormalities in the proteins. But remember that this appearance, whether it is an MPS or spondyloepiphyseal dysplasia, is because of non-development of the ring apophysis. I'll go on for another 5-10 minutes and I will stop. Now, the last two is something I've not talked about. Platyspondyly and atlantoaxial dislocation, and that's where you come in. In Morquio's disease, which is normal mentation, I don't know if you've seen a patient with Morquio's. They look completely normal. They are hyperactive. They're intelligent, hyper intelligent. They come and sit on your table and jump around everywhere, pick up this, pick up that. But they have an MPS. And it's common to have patients with Morquio's. And the diagnostic feature, do I have an example? No, I don't have an example. The classical appearance of Morquio's is universal platyspondyly. All vertebrae are flat. They look normal density, normal texture, normal everything, but they are flat. They also have atlantoaxial dislocation. That's important. So you have to do flexion and extension view. These are bachus, the odontoid is not developed, so on and so forth, but that's another part of a sub-lecture. But they have atlantoaxial dislocation. So when you see AAD in bachus with the Morquio's, classical, no other MPS has got atlantoaxial dislocation. I mean, what I mean when I say no, rarely. Okay, make it rarely. But classical of MPS, not every child with Morquio's has MPS. I'm talking a lot about spondyloepiphyseal dysplasia. I'm talking a lot about MPS because it's common. I'm talking a lot about Diaphyseal ecclesia because it's common. Please read bumpy bone. So atlantoaxial dislocation is something that you have to pick up and inform the referring physician, and the patient has to have a collar. I know 2 bachus who are tripped and fallen and become quadriplegic because somebody didn't give a collar. 2 patients in 40 years is small, but for those bachus, it could be eminently avoidable because as far as the mother is concerned, my child is normal. He or she is short, but my child is normal. So quadriplegic is worse than death. So it's your call. Immediately call the referring physician and say, there is AAD, please give a soft collar, whatever. It's uncommon to have neurological deficit, but you don't want that uncommon, desperately bad neurological deficit. So both platyspondyly and atlantoaxial dislocation are classical of Morquio's disease. Now, this is not abnormal. This is not a dysplasia because there's so much osteoporosis, and you look carefully, you will see the bone density is abnormal. The trabecular pattern is abnormal, and this is a child who has platyspondyly with abnormal bone texture and abnormal bone density. So you want to call it a dysplasia, call it a dysplasia, but this is classical. Platyspondyly with abnormal bone density, which is less. Platyspondyly with beaking and normal bone density is an MPS. Platyspondyly, decreased bone density, no beaking. If it is a skeletal dysplasia, often in the child it is osteogenesis imperfecta. So how do you tell one from the other? This is an MPS, grossly abnormal, anterior beaking. This is osteogenesis imperfecta. The vertebrae look as if there are multiple compression fractures, otherwise they are normal. There is osteoporosis and abnormal trabecular pattern If you see something like this in a child, 100% diagnosis of osteogenesis imperfecta, but you have to see it in a child. Okay, so I'm telling you so many examples of 100% diagnosis. I'm not making it up. I'm not making it easy for you. It's how it is. Some of these common skeletal dysplasias present classical findings which you can make a diagnosis of on 1 or 2 radiographs. Oh yeah, I got a comparison here. Lovely. So on your left is an MPS, on your right is osteogenesis imperfecta. Look at how different the vertebrae are. Okay, Wormian bones in osteogenesis imperfecta. They are also called as sutural bones. You see multiple small multiple small bones. Homework. Why are they called Wormian bones? So I'm giving you lots of homework. But the most important of all these homework is bumpy bones. So this is OI, thin skull wall, looks black. You often get open fontanelles, not always, but you get multiple worms, worm-like bone. No, I'm sorry, I should not be saying that. Multiple bones within sutures, and this is classical of osteogenesis imperfecta. This is a skull, of course, bulging skull, very thin and keeps expanding because of pulsations of the brain. And these are normal children. Okay, so if you have a look at the eyes of these bachus, they are not blue, blue, blue. You have to look them in good light, and you'll see that they are faint, often faint shade of blue and gray. Yeah. I mean, I have looked at patients so often that I cannot get over the joy of making a right diagnosis for these patients when often it has been missed, or even when it has been made in the past. So this is what the difference is. Let's go back. Wait a minute. MPS on the left, osteogenesis imperfecta, more of osteogenesis imperfecta. So you have multiple Wormian bones in osteogenesis imperfecta. You can see that also in pycnodysostoses, but the whole skull morphology is completely different one from the other, just in case they ask you in the exam. Okay, this will bypass, this will bypass. Now, look at the two femurs. The first thing that strikes you is the neck of the femur does not show normal tubulation. This is what I meant. One look at it and you know that this is skeletal dysplasia. Besides, it's symmetrical. I didn't say bilateral symmetrical, just symmetrical. So there's non-tubulation of the neck of the femur, and you know that this is skeletal dysplasia. Non-tubulation is a developmental abnormality, so it has to be a dysplasia. Okay, you can't miss this. But both of these, I mean, you may believe me, you may not believe me, show ground glass opacities. The neck of the femur here, the neck of the femur here. So when you use the word ground glass opacity, when you have to use the word ground glass opacity for something which is soft trabecular pattern, it is diagnostic of fibrous dysplasia. No other disease has the word ground glass opacity, whether it's unifocal or whether it's a part of a syndrome. Ground glass opacity is fibrous dysplasia. Now the point is that whether you pick up, see, I was prepared for a long lecture. Whether you pick up this as fibrous dysplasia or not is a little okay, but you cannot miss that this is a skeletal dysplasia. Now the epiphyses are abnormal and the adjacent metaphyses are abnormal on both sides, up and down. And the reason I'm showing this is look at the lower end of the femur on the left side. That's relatively more abnormal than the one on the right side, which is non-tubulation, right? When you see abnormalities like this, epiphyseal and metaphyseal, you look at which is predominantly abnormal. Here it's metaphysis, which is predominantly abnormal. There is valgus angulation of the knee joint. It's a dysplasia. So this is a metaphyseal dysplasia. So I'm just sort of revising what we have seen already so that you get this into your head, that there are common diseases which is classical pattern and you should not be making the wrong diagnosis. Okay, so we went through that. This is the lower end of the radius. This is another example of a metaphyseal dysostosis. Most bones are involved. It's not a rule that every bone has to be involved. I may have said that, but that's usual. But every time, every bone does not have to be involved. So we have spondyloepiphyseal dysplasia. There are multiple varieties. I'm not talking about this slide. This is another non-tubulation of bone. You have ground glass opacity, which is classical fibrous dysplasia. This is the same as the previous one. This is a localized view. First of all, appreciate non-tubulation. Ignore the obvious. You see lesions in the femur. There are lesions in the ileum, in the supraacetabular region, and the one above that. So when you see multifocal like this is part of Albright syndrome. It's not just local fibrous dysplasia, a whole lot of clinical implications on that. So if you feel like you can read about this, but read bumpy bones. Now look at this frontal view, lateral view, and look at this one. Now when you don't know what's going on, you see a whole lot of calcification, here in the distal metaphysis of the radius and ulna, more prominently seen here at the lower end of the femur and the upper end of the tibia and fibula. What do you see? You see abnormal looking bones, and you see a bunch of calcification in the metaphysis in diagnostic of enchondromatosis. If you have other ideas of enchondromatosis, then you'll see multiple enchondromas, erase them, right? In enchondromatosis, which is a dysplasia like Diaphyseal dysplasia, the bones are abnormal in the metaphysis. In Diaphyseal dysplasia, you get small bones coming out, one or more. But the important thing is the diaphyses are abnormal. In the metaphyses are abnormal. The same thing happens in enchondromatosis. This may superficially look like diaphyseal achalasia, but you don't get this kind of calcification. So calcification means there has to be cartilage. So this is enchondromatosis. It's easy to make a diagnosis. This is a spot diagnosis. Abnormal bones, calcification all over in the metaphysis, close your eyes, enchondromatosis. So many examples of spot diagnosis of, this is not very common. I must grant that this is not common, but when seen, this is diagnostic. Now, this is what I said. I'm testing you here. Abnormal looking bones. What you see here is a small bump here. What you see here is a bump. What you see here is something oval. So this is the end-on appearance of something like this. Imagine this from this view. So this is, for example, sometimes you see just this damn thing, okay? Lower end of the femur. The first thing is that there is not normal tubulation. Again and again, it comes to that. Look at this one versus this one. This is slightly wider. All of this stuff is osteochondromas. So as opposed to enchondromatosis, multiple exostoses is much more common world over, and in our country is particularly common. And there's a whole lot of implications of diaphyseal achalasia. Now I'm not going to say read bumpy bones. Okay, I've said it enough. Now what do you make of this? No clavicles. No, the clavicles are seen. This is a lordotic view. Now here what you have is coarse trabecular pattern. Let's not get into that. I've exceeded time too much. So this is the summum substance. So I've shown you examples of sclerosing bone dysplasias, how to tell one from the other. And I've shown you gestalt of multiple other dysplasias. What I have shown you, honestly, constitutes 80% of skeletal dysplasias that you will see. Most of us will see. The rest 20% are difficult, right? So what are the big 10? MPS, look at hands, pointing on the base of the metacarpals. SED, spondyloepiphyseal dysplasia, same thing, everything looks the same, but the metacarpals are not pointed. Metaphyseal dysostosis, multiple metaphyses involved, lots of sclerosis, no brush border appearance, secondary abnormality of the epiphysis, dwarf-mentally normal, so on and so forth. Fibrous dysplasia, ground glass appearance. Achondroplasia, normal interpedicular distance. Osteopetrosis, is the one which is a bad one. When you have sclerosis of the skull base, you're narrowing of the foramen, and so on and so forth, bone within bone appearance. The most common of sclerosing bone dysplasias. I have not talked to you about craniostenosis. I have not talked to you about clipophile abnormality. So they are in that sense not metaphyseal disorder, not dysplasias, but fairly common structural abnormalities. If you don't know, look them up. Diaphyseal eclasia extremely uncommon. I mean, extremely common, extremely important to pick that up. The most important thing is the modeling of the bone is abnormal. Then you start looking at the exostoses. That fellow who is seen end on can look funny, right? Like a small oval fellow. And then you see the modeling defect and you know that this is exostosis. And rib vertebral dysplasias are the ones that are associated with often with congenital heart disease. So this is some sort of list. I don't know if it's in that order, but this is some sort of list. And you know that the ones that I said are easily differentiable one from the other. Okay. Now this is important. It happens to me very often these days. So the one that I'm sent now are the ones that many have not been able to diagnose. I'm sort of some sort of local expert in skeletal dysplasia. I'll show you examples of that. So when you don't know something, how do you do? How do you find out? Now, if you get to that stage, you have to have a book called Radiology of Syndromes and Metabolic Disorders. I'm sure this doesn't interest most of you. There's a big book which costs 20,000 rupees, and there is a handbook of this by the same author which costs 2,000-3,000 books. It's like Google. So you look at the X-rays and you say there's metaphyseal abnormality, this abnormality, this abnormality. Look up this book. It tells you metaphyseal abnormalities with sclerosis are seen in 10 conditions, so on and so forth. So you sort of cut it down to a small number, and you should be able to look at the clinical findings. So this is optional extra. You feel like you look this up. The easy way may be take a picture of this and do Google image search. Who knows, in 5 years from now, Google image search will tell you the diagnosis of a skeletal dysplasia. Okay, then this one. And learn to say, I don't know. I do it all the time. I get this referred from all over the place and I say, I don't know. I have no idea. And then finally somewhere it goes into somebody's record called it not yet diagnosed. So the difficult ones are really difficult. I told you that there are uncommon ones and uncommon presentations of common ones. So I don't know is simple. And I keep saying this nowadays very often. Because the common ones, many others have already made a diagnosis. So anywhere in life, it's nice to say, I don't know. Be honest and say, I don't know. Don't bullshit. So this is true. Always seek help when you don't know what's going on. So there are people in Chennai who are much better qualified in skeletal dysplasia than I am. There's a lady at CMC in Chavelo who does this for a life. And so there are 3-4 people in the country who will tell you what is happening and never hesitate to seek help. This is what happens, and I don't like this. This is a search of my email of opinion on skeletal dysplasia. I get this all over the place. I don't like this. I don't want to do this. Tomorrow I might be dead. What happens? So that's why I want at least a few of you. If there are 50 people in our audience, just one of you, youngsters, take an interest in. I'm not saying you do just skeletal dysplasia. Take more than a passing experience of skeletal dysplasia. See the patient every single time, and you will make it a career. Because this is skeletal dysplasia. These are the bachus who will come to you. And you look at them, they are mentally normal. And you look at the stories from their mother, they ask you the same one question. Will this child, this mother cried. All through her consultation, she cried. Will my child be normal? Will he grow to normal height? The child gets bullied in school, all sorts of problems, right? So when you look at patients and their relatives, I promise you that you will take more than passing interest in skeletal dysplasia, not because it's a curiosity, not because it will be asked in exam, because you can contribute to the well-being or mental satisfaction of so many unfortunate patients. Thank you.
Thank you very much, sir. It's a very difficult topic, and I hope that most of the people must have learned at least 70 to 80% whatever has been told to them, and that will help them in their practice as a student as well as the consultant. Thank you very much, everybody. Have a nice day and a safe life. Thank you. Bye-bye, sir.
Bye. Thank you.